I would again like to just echo my appreciation of all of you coming out to learn about melanoma on a beautiful day like today. I'm really excited to have the opportunity to talk with you about prevention and inherited risk and other genetic aspects of melanoma. Oh, it's right there. Okay. So just as a general overview, we'll talk about some of the general melanoma risk factors, familial melanoma, or melanoma that runs in families, the genetics of the melanoma tumor, because that is a little bit of a different kind of genetics, screening and prevention strategies. Dr. Kendra already alluded to some of the issues of the burden that we really have of melanoma, and I know that a lot of you have already been touched by this and know this on a personal level, but these statistics can help us kind of determine what it's looking like on the national level here. And these are statistics from 2014, which are the most recent that were available. We can see, again, this is cancer incidence in males and females, and we can see that melanoma of the skin is actually the 5th most common cancer in men in the United States, but accounts for about 5% of the cancers that are diagnosed. Whereas in women, it's a little bit less common in that it's the 7th most common, and again accounts for about 4% of the cancers that are diagnosed in women in the U.S. in that year. However, as Dr. Kendra alluded to, the incidence of melanoma has really, really increased over time, and this is basically looking at the last half of the 20th century, looking at the increase versus decrease in diagnosis of different types of cancer. And you can see that melanoma, unfortunately, is the clear winner here. It's the top line, the purple line, outstripping lung cancer, outstripping breast cancer, outstripping prostate cancer, outstripping all of them considerably. And so, people allude to the melanoma epidemic, and that really is, what has been going on. Some people feel that this increased incidence of melanoma may be due to the fact that we're finding a lot of very, very early melanomas in terms of melanoma in situ, or very thin melanomas that generally are not going to be life-threatening. And this is a graph that looks, the pale area is the incidence of melanoma, and we do see that the darker area is the mortality or death from melanoma. We can see here that, however, there is still a steady increase, not as dramatic as the incidence, but still a steady increase in mortality through 1950 to 2000. One other thing that's important to look at in these slides, though, however, is, as Dr. Kendra alluded to, and as Dr. Grossman will be talking about later on today, this is before some of the, quite frankly, paradigm-changing drugs that have happened really in the last 5 years. Again, looking at the change in cancer mortality, we see that melanoma in this slide is the red bar, and other cancers like prostate, breast, and colorectal cancer, as well as cervical cancer, are the other bars. And we can see that melanoma is the cancer that's going in the wrong direction in terms of mortality, again, through 2000. So a bit of a historical perspective here. In terms of the lifetime risk of developing invasive melanoma in the United States, in 1930, it was about 1 in 1,500. It was a pretty rare disease then. However, the incidence has increased markedly, and at this point, they project for 2015 that it was about 1 in 50. So again, about a 2% lifetime risk of developing melanoma now. So looking at risk factors, a lot of people have a basic awareness of melanoma risk factors, but there's some nuances, and also I think it always helps to try to quantify some of these risk factors as well. So a lot of people think of skin cancer risk as being associated with continuous sun exposure. And although that's true for non-melanoma skin cancers, melanomas have actually been more associated with intense intermittent sun exposure. People who perhaps don't have a lot of sun exposure on a daily basis and then go on vacation somewhere tropical and get some intense sunburns, particularly during that time period. Sunburns in childhood have also been associated with an increased incidence of melanoma. And we can see that an intense sunburn, and I'm talking about a blistering type of sunburn, can increase melanoma risk by about 2 to 3-fold. The skin type, your skin type, of course, can also increase risk. Here I write down skin type 1. There's a classification of skin types that dermatologists use to classify skin. And that looks at things like how easily your skin burns, how easily your skin tans, and what kind of pigmentation is present in your skin. So skin type 1 is, of course, the fairest type of skin. And that, of course, just by virtue of having that relative lack of pigment, you're going to have about a double the average risk of melanoma as well. And then other risk factors have been, for example, blue eyes often go with a fairer complexion as well, and that can increase the risk a little bit more than 1.5 times. Other things, of course, are having atypical moles. And, it depends a little bit for the risk factor on how many of those moles you have and whether or not you have a family history of melanoma. And like I said, we'll be talking about family history more in just a minute. But having what we call atypical moles or dysplastic nevi without a family history can increase the risk. And different studies have said that that increases the risk by 8 times to 50 times. So it can have a significant impact even without a family history. If you do have atypical moles and family history of melanoma, then that can markedly increase the risk 100 to 150 times above the baseline. And again, if you have more than 100 moles, then that can increase the risk 10 times even without a family history. A family history, again, by itself, without a history of a lot of moles, can increase your risk. If you have one first-degree relative, that would be a parent, a sibling, or a child, then that will double your melanoma risk. So anyone who's had melanoma, their immediate family is at mildly increased risk of melanoma as well. If you have 3 relatives who are first or second degree relatives, and second degree relatives would be things like grandparents, aunts and uncles, things like that, then that can increase the risk 38 times above the baseline. So knowing the family history actually is really important, and we'll talk more about that in just a minute. Oops. Can you still hear me? Okay. So talking about familial melanoma, familial malignant melanoma, usually we use this term for families who have 2 or more first-degree relatives, again, parent, sibling, or child with melanoma. It's important to realize that about 8% of people newly diagnosed with melanoma have at least one first-degree relative with melanoma. A small proportion have 3 or more close relatives, about 1% with melanoma, and we do want to identify those individuals because there could be something inherited, passed from generation to generation, that's causing that inherited predisposition to melanoma. So some of the mutations that we look at that are passed in genes that are passed from one generation to the next are listed here. The one that we think about most frequently for inherited risk of melanoma is called CDKN2A. It's also called P16. There's a disorder called Xeroderma Pigmentosum, which can be associated with non-melanoma skin cancers and also with melanomas as well. A very new gene on the scene, if you will, is called BAP1, associated with both melanomas of the skin, but also melanomas of the eye. And then some genes that may come up a little bit more commonly when we think about hereditary breast cancer risk, such as BRCA2, can have a mild increased risk of melanoma, as can PTEN, which is also associated with breast cancer risk. And I'm going to talk a little bit more about each of these. I'll start with CDKN2A, or P16. And again, having a mutation in this gene is associated with a syndrome called Familial Atypical Multiple Mole and Melanoma, or FAM, with 3 M's. I'm not quite sure how to pronounce 3 M's in a row, but I just say FAM. This is a rare disorder. Remember I said that there's only about 1% of individuals who have 3 or more relatives with melanoma. But it probably is under-recognized because, again, a lot of times we're not necessarily thinking about this when we're thinking about melanoma treatment and other things like that. The likelihood of having a mutation depends on the number of people who have melanoma in the family. For example, if there's only 2 people with melanoma in the family, there's about a 14% chance. But if there's between 7 and 10 people with melanoma in the family, then that's a virtual certainty that this gene is altered in some way in the individuals in that family. People who have CDKN2A tend to be diagnosed at an earlier age for their melanomas, generally in their 30s rather than in their 50s to 60s. And having this kind of mutation can predispose you for other types of cancer, in particular pancreatic cancer or a type of brain tumor called astrocytoma. So certainly when we see people in the clinic who have a family history of melanoma and pancreatic cancer, our antennae start to go up to think about P16 mutations. Xeroderma pigmentosa, again, is another rare disorder, but again, the effect on skin cancer risk is quite dramatic. This is something that generally manifests in childhood, and it's present in about 1 in a million live births in the Western countries. In countries like Japan, it's a little bit more common. But basically, these genetic alterations in a group of genes cause a defect in DNA repair. When the sun hits our skin, it does cause damage to our skin. And normally, our cells are able to repair that damage. But if these DNA repair genes are altered, then we're not able to make those kinds of repairs. So these individuals have an increased sensitivity to sunlight. And often have to wear extreme protective clothing. Now, this is not something that I'm recommending that all of you go out and get or anything like that, but just to kind of underlie the extremeness of this disorder. They have 1,000-time increase in melanoma risk over average. They also have a markedly increased risk of non-melanoma skin cancers, and these non-melanoma skin cancers can occur on average at the age of 8. So again, affecting people very early in life and in a very dramatic way. This is an example of some of the sun protective clothing that is used for individuals who have Xeroderma Pigmentosum. And these are the children that sometimes they have in the news and things like that that can only really go out and play at night and have to wear a full body covering as well as covering for the face, where oftentimes those non-melanoma skin cancers can occur. So moving on then to our next gene, which is called BAP1. And again, this has only really been we've really only known about this for the last 5 years or so. It's called BAP1 stands for BRCA associated protein 1. And they've recently given a name to this syndrome. I'm not a huge fan of this name, but it's called the common syndrome, even though it's not a common disease. That stands for cutaneous and ocular melanoma and atypical melanocytic proliferation with other internal neoplasms. So, like I said, I find it a little bit misleading name because it is not a common disorder, but it is associated with melanomas of the eye or ocular melanomas. It can also be associated with certain kinds of kidney cancers, mesotheliomas, which is a specific kind of lung cancer, and possibly basal cell carcinoma. And we're still finding out about others. And OSU in the genetics group is leading the way in researching this particular gene. I do want to talk briefly about BRCA1 and BRCA2 because these are the genes that most people think about when they think about inherited cancer risk. Of course, these genes are associated with an increased risk of breast cancer and ovarian cancer primarily. BRCA1 hasn't really been shown to have an increased risk of melanoma. BRCA2, there have been some studies that suggest that there could be a mild increase in melanoma, talking about maybe a twofold risk. You can see here that the one large group called the Breast Cancer Linkage Consortium found a relative risk of melanoma of about 2.58 or 2.5 times the increased risk. There was a second study that had a similar increase in risk, although it wasn't powered enough to make that statistically significant. There have been other studies, however, in the Netherlands that showed actually a decreased risk of melanoma in people who had BRCA2 mutations. So the story is a little bit clouded right now. And looking specifically in the Ashkenazi Jewish population with melanoma, the reason I look at that is because the BRCA1 and BRCA2 mutations are more common in that population. And they actually did not find an increased prevalence of those mutations in Ashkenazi Jewish individuals with melanoma. So this story for BRCA2 is still developing, and I think it's going to continue to be very interesting. PTEN, again, is another gene that can be passed down from one generation to the next, associated with breast cancer, uterine cancer, and thyroid cancer. Now, we know that PTEN genes are altered in a lot of melanoma tumors, but the question really is, are those genetic changes that can be passed from one generation to the next? So they have found in some small studies that the incidence is about 8 to 8.5 times more often for people who have PTEN to have melanoma than they would expect normally. So it does appear that that risk is increased over the general population as well. There are also some other genes that are kind of up and coming. They're not generally tested for as often clinically, but it can include TERT, POT1, MITF, and MC1R, which are not technically mutations, but variants. MC1R tends to be associated with individuals who have red hair. And of course, individuals with red hair are kind of a classic, what we call phenotype or physical appearance for individuals who have who are susceptible to melanoma. So having said all this, when should someone actually think about seeing a geneticist about their melanoma risk? And they do have set guidelines for this. If someone has themselves 3 or more primary melanomas, that is 3 melanomas that have arisen separately, independently of each other, that suggests that perhaps that you're at an increased risk, that all of your skin perhaps has changes that makes you more susceptible. That would be a time to come in and see a geneticist to think about genetic testing and evaluation of your pedigree. A personal history of melanoma and pancreatic cancer. Again, we talked about P16 or CDKN2A being associated with pancreatic cancer. So those individuals definitely our antenna would be up. A personal history of melanoma and astrocytoma, or again, that specific kind of brain tumor. If there's 3 or more cases of melanoma or pancreatic cancer in a group of first-degree relatives, or if there's melanoma and astrocytoma in 2 first-degree relatives. So these are all instances that we would think about that. So I've talked a lot about genetic mutations that are passed down from one generation to the next, and you may be thinking, okay, she hasn't talked about any of the genetic mutations that my medical oncologist talked about when they're thinking about how to treat me. And that's because there's really 2 kinds of genetic mutations. There's somatic changes and there's germline changes. So somatic changes are changes that happen within the cells during a person's lifetime, whereas germline changes are present in that individual from their time of birth and even actually the time of their conception. Somatic changes are present in cancer cells only. If I were to draw your blood and look for somatic changes, I would not find them unless you had a blood cancer. Whereas germline changes are present in all cells of the body, and that's why we can test for things like P16 by doing drawing a blood specimen from you. Somatic changes are not inheritable. They are not passed from one generation to the next, whereas germline changes are inheritable. And somatic changes do not cause family cancer syndromes, whereas germline change, and an example of a somatic change that does not cause a family cancer syndrome is the BRAF mutation. And many of you have probably heard about the BRAF mutation in talking about melanoma, because we have drugs that can be actually targeted against those BRAF mutations. Germline changes, on the other hand, can cause family cancer syndromes, and the example for that is CDKN2A and BRCA1 and 2, like I was talking about before. So just to briefly touch base on the genetics of the melanoma tumor, I've mentioned BRAF mutations before. They tend to be associated with melanomas that occur at all different kinds of sites. They are primarily in skin that does not have chronic sun damage. Mutations in a gene called KIT tend to be in a specific kind of melanoma called acrolentigenous melanoma, which occurs on the palms of the hands and the soles of the feet. And Dr. Tarando will be talking a little bit more about these melanoma subtypes when she gives her talk. KIT mutations can also be associated with mucosal melanomas, or melanomas of the lining of the mouth, the nose, the gastrointestinal tract, the genitourinary tract, etc. They can also be found in areas with chronic sun damage, like on the face. NRAS mutations we use because we have drugs that are targeted against changes in the MEK gene, or the MEK protein. And the NRAS gene change is basically a surrogate for looking for susceptibility for those MEK targeted drugs. So this graph kind of breaks down the distribution of these somatic mutations in BRAF, NRAS, and c-KIT by where the site of the primary is. The first column is non-chronic sun damaged skin, and we can see that over 50% of those individuals have a BRAF mutation, and then a proportion of those also have NRAS mutation. And chronic sun damage, which is the second column here, we see that there is a good proportion that has KIT mutations, and that the BRAF proportion with BRAF mutations is much smaller. Acrolentigenous, again, we see a small proportion of BRAF mutations, but a large proportion of KIT mutations. And the mucosal, again, a large proportion of KIT mutations and a relatively small proportion of BRAF mutations. So I'm going to shift gears now and talk a little bit about skin cancer screening. I think, and this is something that is really important to us in the clinic, and I know our nurses work really, really hard on this in our clinic. Education about sun safety and the warning signs of melanoma, thinking about monthly skin self-examinations, full body examination by a dermatologist at least annually, not just looking at, places that you think that you're worried about, but actually doing a head-to-toe kind of examination. Particularly with people who have a lot of moles or nevi, thinking about things like full body photography or dermoscopy, which is using a handheld tool that's kind of a combination between a microscope and a magnifying glass to help look at the structure of the skin and the structures immediately underlying the skin to help determine whether or not a lesion looks like it might be cancerous. Again, we don't generally recommend removal of moles unless they have concerning characteristics. And what are those concerning characteristics? Well, we think about the ABCDEs, and I think probably many of you have probably heard this rule before, but it always does bear repeating. The A is for asymmetry, or difference in one side of the melanoma from the other. B is border. If there's an irregularity to the border, that suggests that that mole is not growing in a uniform way and that melanoma might be present. If there's differences in color, which is the C, then certainly difference in colors within a mole is something that would be a warning sign. And diameter is the D. In diameter, we usually say if a pigmented lesion is bigger than 6 millimeters or the size of a pencil eraser, then generally it's something that is going to be brought to our attention. The E, which there's not really a good picture of, is for evolution or change. Certainly any mole that is changing is something that needs to be brought to the attention of your physician or your dermatologist. I do want to talk a little bit briefly about ultraviolet radiation and what we do to combat ultraviolet radiation. So there's two kinds of ultraviolet rays, UVA and UVB, and you may have heard about these on television, but UVA is more abundant, but it tends to be less potent than UVB. It's present all of the time, even on cloudy days, which means we get it even here in Ohio. It penetrates deeper into the skin than UVB, and it tends to cause aging of the skin rather than sunburning of the skin. UVB tends to be more potent, however, biologically, and is more likely to cause DNA damage to the skin cells. It tends to be the causative agent for sunburn and for skin cancer. And the primary thing that we look at in sunscreens, the SPF, blocks UVB radiation. So just a little bit of discussion about sunscreens and sunblocks. What is the difference between them? So sunscreens absorb the ultraviolet light so that it actually doesn't reach your skin, whereas sunblocks physically block the UV rays of the sun. Again, as I mentioned before, SPF only rates protection from UVB, but generally we recommend that our patients who are wearing sunscreen should really get something that protects them from UVA and UVB rays both, because and these are widely available. The products that we usually think about have ingredients like titanium dioxide, micronized zinc oxide, Helioplex, and Mixoryl, and I think that these are listed in some of the handouts that you were given up at the front. The question I always get asked too is, what kind of SPF should I use? More is always better, right? It's like, that is true, but there is some diminishing returns to that as well. We look at SPF 15, that blocks about 95% of UVB, whereas SPF 30 blocks about 98%. Going above SPF 30, you may have incremental benefit, but really we say, having an SPF of 30 or greater is what we would recommend. The other thing, though, that we do have to think about is that sunscreen, in order to be effective, has to be applied appropriately. We recommend that it's applied 30 minutes before you actually go out into the sun. We recommend that it be reapplied after an hour and a half in the sun, or if you're sweating or if you're in the water, it may have to be reapplied more frequently. So those are things to think about. Also, I think it's important to think about things like sun safety, avoiding the peak hours of the sun between 10 and 4, looking for shade structures, and of course having appropriate cover up in terms of having a hat with a 3-inch brim all the way around, and having appropriate clothing to cover up as well. And I know there was some information about protective clothing as well at the booth, I believe, as well. So I've been talking about sunscreen and melanoma. So what is the scientific proof behind that? And I think, we've been saying this for a long time, but there was a very important study that was published in 2011 that demonstrated pretty dramatically how much of an impact sunscreen can actually make in preventing melanoma specifically. This was a randomized study, and basically this large group of individuals, 1,600 people, were split in half and randomly told you can put on sunscreen whenever you feel like it, or you need to put sunscreen on daily. Okay, and they compared the rate of melanoma between those two groups. The people who had daily sunscreen had a 50% reduction in melanoma diagnoses at 10 years, and they had a 73% reduction in invasive melanomas. So, some people would make the argument, well, maybe you're only preventing the thin melanomas that are easy to treat, but they actually had a significant reduction in the more serious invasive melanomas as well. A lot of people say, putting on sunscreen is kind of annoying and it's hard to do, and, I have to keep putting it on and I don't like to do that. Are there medicines that I can take to help prevent melanoma? And this is an area of a lot of research. The short answer is we don't have anything that's proven at this point in time, but there's a lot of things that we've been looking at. Non-steroidal anti-inflammatory drugs. We know that inflammation is one of the components of cancer, And the idea is by reducing inflammation in the body, can we reduce cancer risk? So that's something that's been under investigation. The other thing that we think about is vitamin D. Vitamin D is, of course, associated with sun exposure. And could vitamin D use actually help to prevent melanoma? We don't have answer for these right now. The other thing that we've looked at is statins, the cholesterol-lowering drugs. Again, they have some anti-inflammatory effects as well. Perhaps they might be effective. And of course, a lot of people are taking them for other reasons, so you could have more than one benefit from those. So those are all things that we've been thinking about, but at this point, we don't have any conclusive answers to provide for recommendations. But it remains an area of intense research at this point. So just some take-home points here. You know, it's good to know your family history because that can help determine your risk of having second primary melanomas, or having other cancers, or and knowing what's going on in your family can help determine who else might be at risk. Genetics can help determine not only the risk of melanoma, but also can determine the treatment options when we look at the genetics of the tumor itself. And then, of course, sun safety remains the best prevention. So this is a quote that I borrowed from a commencement speech that was given by Kurt Vonnegut to the MIT class in 1997. It says, "Be careful whose advice you buy, but be patient with those who supply it. Advice is a form of nostalgia. Dispensing it is a way of fishing the past from the disposal, wiping it off, painting over the ugly parts, and recycling it for more than it's worth. But trust me on the sunscreen." That was Kurt Vonnegut. So these are some resources just in terms of skin cancer information in general. The first two are from the National Cancer Institute. The first is basically about skin cancer, and that's a patient lay level kind of information. Whereas the second is a more in-depth look at skin cancer genetics, also at the National Cancer Institute. That one is written on the level of a healthcare provider or a sophisticated layperson. It is a little bit more complex and certainly more involved than the other page. The other link that I have here is a link to the U.S. Surgeon General Family History Initiative, which gives some tools to help talk about an organized family history of cancer and other diseases. So with that, I'd like to end my talk and thank you very much for your attention and for having me here today.